Thank you very much for inviting me to come here. 20 years ago, I used to live in the city. It's very good to come back. And thanks to Patricia. We talked to each other over the phone 6 months ago, the co-chairs, Chris and Beth. And I think that the wise words that Susan addressed us in this morning is going to give me the background of what I'm trying to say. The next one, please. There is no way to yeah. Okay. I think the background is the same background that you gave to us. So we have aging population, information is circulating over the internet. Everyone knows something about health. We have an endless myriad of interventions possible in any professional health practice. Plus, we have a globalization where universal health coverage is right now under discussion in all is going to be more important right now in the UN Assembly in September. I think that the decision about non-communicable diseases makes things harder than before, because it was just epidemics, just vertical programs. We don't have vertical programs anymore. So if I have to take care of diabetes, I have to take care of hypertension, of course it gives more work for the health sector and intensifies the scarcity of health professionals that we have. So the figure that we have right now that, I don't know, there is some misconfiguration here. The figure in the third global forum in Recife was about 7 million, a lack of 7 million health workers in the world. Probably the things are going to be worse than this. So the question is, how can we pay the bill? Just to take an example, Brazil spends on average 10% of what you do. And I think that first quintile, or let's say the top 2% of our population spend the same thing, because the big and great hospitals in São Paulo, Brazil, Rio de Janeiro, Brazil, have the same level of complexity that you have. So it's just to make the figures. If we spend on average 10%, and the top quintile spends the same, there is few resources left for the rest of the population. But in Brazilian case, when we decided to write a new constitution back in 1985, 86, 88, 7, 8, in a constitution we have four articles that say clearly, that states clearly that health is a right of every citizen in the country and a state duty. I'm not going deep in the constitution, but it's like our wishful thinkings are in the constitution. We put all of them there. How to make it? It's what we are struggling now. In our case, about 70% of the population depends exclusively on the national health system, about 30% by private plans, and the fact that there is a lot of people coming from poor segments of population to middle classes in Brazil in a certain way, and it's like a contradiction, because they want, as part of the packet of the being middle class citizens, to have a private insurance. So it's like a contradiction that we have right now. But anyway, the national health system in Brazil covers 100%. If we think about vaccines, emergency care, epidemiological surveillance, everything is, it's because it's the Constitution. And it is like a paradox, because highly complex procedures in Brazil, such as organ transplantations, we are the second country in the world in number of organ transplantations in public funded, the first one in public funded, immediately after you. All of them, because in the Constitution, because the Constitution states that is a right of the citizens. Everyone, for instance, if a citizen has a prescription for a very, very expensive drug, he can go to the justice, and the judge asks to the public sector to pay. So you imagine that we have like a sand clock where all the primary healthcare belongs to the public system. The intermediary is somehow divided between public and private, and the highly complex system, despite the fact that the people has insurance, they pay for their insurance, but they have the right in the Constitution to be covered by the public health system. In saying that, it's quite clear there's no way to assist everyone in tertiary and high complex systems. So I think there is no way but to strengthen a primary healthcare system, which can address 80% in the international experience is this. Right now in Brazil, we have about 45 family health teams. They are spread, I'm going to show you a map, in all the country, and cover about 65% of the population. If we think that the 65% are covered by primary health care, 30% has a private insurance, so we can say that almost everyone is covered by health system in Brazil. Family health teams, those 44,000, are composed by physicians, nurses, auxiliary nurses, dentists, and most of them have 6 community health workers that are recruited locally by the municipalities. The system is quite decentralized in Brazil. It's run by the municipalities. They cover, the teams cover geographic population, so there is a population assigned to them. So every team has a responsibility for primary health care for one group of population. I can go to details if you want. And they are decentralized, so we don't have a national career of professionals. They are hired by the municipalities. This shows you, let's say, the political commitment with primary health care. We started in 1998. The white points are municipalities without primary health care teams. It's going dark blue are the municipalities with family health teams. So if you see 98, 2003, 2008, 2013, what we have right now, we don't have right now. I can tell you big. You see some very, I don't know if graphics is good, but very, very small points in red that are the only points in Brazil where we don't have family health teams available for the population. So for us, primary health care is the pathway. It must be integrated with the entire network. It does not make sense to have a primary health care that ends itself or when people need to go to the hospital, doesn't have a referral system. So there's a strong referral system with secondary hospitals, community hospitals, and tertiary hospitals that in Brazil in general are the university hospitals, and let's say networks like dentist assistants, problem of alcohol, drug addiction, and a system of pre-hospital care. For us, it's clear that the main problem that we have is human resources. I think that improving health facilities, building new facilities, buying, procurement of medicines, is much easier than having a properly trained and well-motivated professional team. Motivating physicians to be part of the teams, because we used to have, for a long time in those maps, a plateau in 33 teams. And we needed 45, let's say. What happened is the only constraint that we had to build more teams was to have physicians wanting to go to areas remote with scarcity, without education for the kids, and sometimes with transportation system by boats, for instance, 6 hours to go to the next facilities. It's really hard. So the motivation of physicians to be part of the teams, particularly in urban, peripheral, rural, and remote villages, use it to be the main constraint. So there is a lot of things that we thought about being Minister of Health of Brazil. expanding enrollments, changing curricula, hiring foreigners. We have right now 13,000 Cubans. It's all the newspapers in Brazil you see about the big controversy about the presence of the Cubans in Brazil right now, because the Cubans are the ones that allowed us to come from the 33 teams to 44. It's the only way that we had to do this, but it's a part of the program that expands medical schools. You have 150 medical schools. We right now have 264. We are the second country in the world, immediately after India, in the number of medical schools. We are offering e-health for anyone in those practical primary healthcare units. Continuous education, those are policies. I'm going just to pick two of them to give an example. Otherwise, I should have talked about 40 years of experience for 4 days here. You don't have time to do this. In education, Brazil used to have a very conservative tradition, you know about that. I don't have to tell you. Professional education. For all the professions, we have 14 health professions in Brazil defined by the National Health Council. Physicians' rate is still 1.9 per 10,000. You have much more. However, this is the program that I mentioned before. A federal program was recently launched, opening new medical schools, adjusting the number, and making that the new schools should be different. Because I agree with Susan, because an old professor that works with me told exactly this idea. We have institutions of the 19th century preparing people born in the 20th century to practice in the 21st century. So it's exactly this idea. How can we cope with this idea of putting the things together? So this program is quite controversial politically in Brazil, but I'll give you the idea. We try to think about 3 axes. First one, in all the being medical schools for 40 years, the first axis is the learning scenarios. The second one is health concept. The third one is methodology. What we have in Brazil is basically most of the teaching, especially medicine, was in tertiary hospitals. In the health concept was based on diagnosis and treatment of complex diseases. I think that we have the same. And the methodology, teacher-centered and lecture-based medicine. I think, how can we change this? So this is in red because we thought about like a metaphorical traffic light. So this is the red light. This is what we don't want. But we try to build new scenarios. The yellow, for instance, in the learning, in the axis of the learning, we can have instead a university hospital and ambulatory cares. That when I was educated as a physician, there was practically no ambulatorial care was in my teaching. In the health concept, prevention, diagnosis, and treatment instead of just diagnosis of complex diseases. We can bring it in the yellow for the most common diseases. In the methodology, you can have some level of innovation, such as PBL, etc. But we can go further. So we thought about what should be the green light for us. So in learning scenarios, for instance, we think that the primary health clinics and community health centers should be the perfect scenario for those ones that are going to practice on those scenarios in the future. We thought about in the axis of health concept, health in all policies, that's the same idea of social determinants of health mentioned here already, policies, promotion, and primary health care. And we thought in the area of methodology, in a student-centered, active, critical learning. So this is a metaphorical approach that what we want in Brazil is make disappear all the red lights and yellow lights and red lights, and this is the scenario that we want. So this is a metaphorical approach that I think that we use it. Ministry of Health started to give money to all the schools in Brazil, starting with the core members of the family health teams, medicine, nursing, and dentistry. But with all of them, asking them to change the curriculum. Why don't you leave the hospital and go to the primary health care center? Why don't you leave the hospital and go to... In order to do this, we have to finance, for instance, if the primary health care center doesn't have a room for to hold meetings or to have facilities or to have internet connection, etc., through many mechanisms, we started to do this. And we, at the end of my term as a secretary there, we had 365 colleges applying for resources from Ministry of Health to change their curricula. And I'm going to give to you, I don't know if my time is, I'm going to give to you, this was the first example, changing curricula. I should go in other one, e-health or etc. But I'm going to tell you a little bit about the second example that I picked there. That is the Open University that I'm in charge right now. I am the responsible for this initiative in Brazil. Open University is of national health system. We in Portuguese, and Susan can speak Portuguese. So Open, Universidade Aberta do SUS, Open Universidade Aberta del SUS, del Sistema Único de Saúde do Brasil. It should be this Open University is set up by the federal government through a presidential decree, and it's composed in the presidential decree by three components. The first one is a network of public universities in Brazil wanting to participate in a program that is not just the education up to the time that the guy takes the diploma. In Brazil, the physicians, they stay 6 years in the college, but after this, 40 years, without public support to go ahead. There is a research in Brazil that the main source of continuous education is quite unfortunate. I told this here in Parma once. I was almost distracted by the physicians there. The main source of continuous education, I'm not saying this, the main newspaper in Brazil said that based on a research, is the visit of the pharmaceutical companies. For most of the physicians in Brazil, I cannot deal with this idea of where the visit of the representative of the pharmaceuticals, the big pharma, should be the main source of continuous education for the health professional. I cannot, having entailed in the Constitution that the health is a duty of the state and the right of the citizen, I cannot deal with the idea where the laboratories have vested interest in making propaganda to have their products as the main source of continuing education. The first component is the consortium. Right now we have 23 federal universities in Brazil, the top ranked of them participating in this program of continuing education, our health professionals. We have right now, there is a mistake here, that is, it has the biggest repository of open educational resources in health in Latin America. We have it. Almost 2,000 educational objects already uploaded in our platform that can be used without, with open access to the knowledge. Everyone in the universities of Brazil can use those materials to start teaching or to start. There's a lot of discussion. If you want, we can do this. But I think we are a little bit different of the MOOCs, for instance, here, because we have the numerator, you have the denominator. I know what are the health workers that I'm trying to reach in Brazil. I have 2 million health workers. For instance, if I know that 200,000 are the ones that are in my system right now, I know that I have reached 10%. So I think that, of course, I think it's wonderful, the experience of the MOOCs that you are used here in the United States. But the difference that we have is that we have the denominator as well. We know, I can plot for you, if you give me a time, where are the orthopedists in Brazil, where they are, because I know all of the professionals that give health, work for the Ministry of Health, I have them inscribed in our database. And yesterday, exactly yesterday, I started to work with I have the control in my database of all the health professional students. So for instance, if a student is in internship and wants to make some course that we are offering, the day before yesterday, he was not allowed to do this because he doesn't have a number of giving health to the national health system. Right now, the students, we signed yesterday an agreement with the National Institute of Education that the students do 4th and 5th year, they can do that. I'll give you just one example, because we started to offer Brazilian, we are clearly linked to the policies of Ministry of Health. Ministry of Health in Brazil started to offer 6 months ago HPV vaccination in the network. It was made free of charge, available for all the girls in Brazil to be vaccinated with HPV vaccination. So Ministry of Health asked us, if we are going to put our vaccine available in the health facilities, physicians, nurses must be trained about how to use this vaccine. So, no, before this, this is the next. Just to tell you a little bit what we are doing right now. We have a specialization in primary healthcare, specialization as a title in Brazil, it gives a diploma, 200,000. We have other specializations. We have our blockbuster right now is this extension in home care. Everybody in Brazil, thousands of people going to this home care. We prepare self-learning, certified modules, let's say influenza, dengue, it's available. Most of them are available on iOS, Android, and it can be run in your mobile device. You can be trained during your time in commuting. We have to face equally equity issues, like we are right now, we have a launching, Ministry is launching coming week, a course about LGBT, indigenous population, Afro-descendants, the problems of sickle cell diseases, etc., that are linked to the Afro-descendant population in Brazil. Right now, there is about 200,000 health professionals enrolled in this continuous education process. The idea is the accessibility is much more through the internet than face-to-face education. It works online, offline, and we are trying to use this kind of games of virtual cities to train the professional to go to the city, know where the risks area, etc. So, it's good because he or she, the health professional in Brazil, can go at its own pace. It can, for instance, to be trained Saturdays, Sundays, or during the night, or the time that. So I think it's a good experience. I'm going just to show to you this, right now, this HPV example. We made it available, and you can see what should be the difference. For instance, after charging this, I saw, you know what's the, this is a small isle in Brazil, Fernando de Noronha. That is this one, where there's somebody in Fernando de Noronha took the course. Otherwise, this is 3 hours flying from Natal. Or if you imagine here in the border, Venezuela, Colombia, Brazil, there is a lot of people here So those are, we plot in the map the professionals that took this course. It's about 40 hours course on HPV vaccination immediately after. So here we have the dates, August, and the number of the enrollees in the course. I think that's the idea. The same happens for dengue, the other influenza, etc. So everything is going simultaneously. It is made available for this network of universities. The universities have a quality control, upload the courses, and the courses start to run. So to finish, I think that the well-educated, motivated manager health workers are the core for the health system. In Brazil, for us, it's quite clear the primary health care is the pathway to universal access, and it can be effective, because if I have just a PHC that does not solve the problem of the patient, it goes to the line of the hospital, it won't make sense. Primary health care must be networking in Brazil with hospitals, with the psychiatric care, with dentists, it must be networked with all the network that we have there. For us, it's clear that health education must be reoriented towards primary health care. And the final is that continuous education must be accessible in order to improve the availability and the quality of the health service. I'm sure that right now, shouldn't we have this offer of the continuous education? It should be still just based, relying on the visit of the pharmaceutical. So this is my presentation. Muito obrigado a todos vocês. Thank you very much. My address is here. Unfortunately, I don't bring the card, but if you want to make any question, I will be glad to answer.